For joining. We appreciate you coming in and being a part of this. This is, as you can see, Stigma 101, and we wanted to make a training that was really simple. This is not anything that we're going to go too in depth about. We're just going to talk about some things that are on the surface right now, and these are real conversational types of bits of information that we want to share with you. There you go to the next. Can you go next? All right. All right. The etymology of the word. This is not me nerding out. I do like etymology. I like to find out the root of words. But as I started to research a little bit more about it, I realized that the word stigma is exactly what it sounds like. It's a burning, leaving a mark on your skin with a hot iron. Some definitions actually say a tattoo, and if anybody has tattoos, we know how difficult those are to get off. It's about it's disgrace and discrimination and prejudices and bigotries, all those types of things. That is what stigma is. That is the definition of stigma. Next slide. But simply put, it's judgment. We're passing judgment on people, not we, but people are passing judgment on people, and I know I have at times. But when we start to talk about SUD and mental health, we're passing judgment. And, I grew up understanding that the saying, I don't know if anybody's ever heard it, but po body's nerfic. So we've all got our issues. There are things that we all may not do as well as the next person. Next slide. So the question here is, who can be infected, but I also emphasize affected. Next slide. And it is everyone. All of us can be. Regardless of our education, our experiences, we all can be affected and infected by stigma without the education, the right education, and the right resources. Next statement. Next slide. So a lot of what we have learned has come from television, radio, movies, and things of that nature. And one of the things you see on movies is you see someone who's in a mental health crisis, or someone who's a substance abuser or user. We don't use abuse, but a substance misuser. They depict them in the worst light whatsoever, and it scares people. It puts people off. They don't want to find out any more about what may have caused a person to come to this place. And a lot of times, in most instances, in my experience and in my career, it is a trauma somewhere down the line when it comes to SUD. Mental health is slightly different. Next slide. But again, like I said, there are two sides to the story, to every story. Next slide. And these are some of the common misconceptions, and I'm not going to read these in any specific order, but I've heard things, and I'm sure you have heard things, they're criminals, and who cares? This is what you've chosen to do in your life, and it sounds like a you problem. If you try hard enough, you can kick this, or you can be better, and all these types of things that they're not really true. There's more to it than that. And this is where we've really got to have those hard conversations with people who say these types of things to us, because largely it's ignorance. And ignorance doesn't mean anybody's stupid. It's just a lack of understanding. And that's what we're here to do today, is to talk about that lack of understanding and how to overcome it. Next slide. And as I alluded to in the previous slide, it is a lack of understanding, and we've got to understand that these are diseases. And if you look up what a disease is, and I've had a debate with people who don't want to acknowledge that they are diseases, when you don't look at them as a disease, then we're quicker to judge. We're quicker to label people with something or as something that they're actually not. And this is when I heard these quotes, the second one struck me the most. When this woman said, "I was told that my son's death is Darwinism. If they saw my son overdosing in the street, they would step right over him and keep walking." And that brings to mind something my mother would tell us years ago. She would see somebody out in the cold, or if someone was hungry or something like that, she would always tell us, that's somebody's baby. That is somebody's child. And if my children were in this position or that position, I'd want somebody to take care of them. So sometimes it causes us to take a step back when we look at it from that perspective. When you see how cold someone could even be to say something of that nature to someone who has just lost their child to an overdose. And then the other one, the first one, when he said I felt hopeless, excuse me, like no one cared. People judged me and I was battling alone. Well, all of us here, this is what we do. We seek to help people who are in these positions, but a lot of times they don't know that they're out there and they think that they're being judged. Next slide. This is some of the emotional impact of stigma, and there are many. Again, we're skimming the surface on this just so that we can bring out some of these things that aren't always talked about. The guilt that people carry, the shame. I mean, I know how I feel when, I feel like I messed up my opportunity. I know, they have, poor familial connections because of maybe their mental illness or their substance use. And then, the thought, the idea that it's like ripping off a scab that just started to heal every time somebody labels them or every time somebody shows some bias against them. And again, at the last, it's a reminder of all of their shortcomings. And we've all made mistakes, and I don't need to be reminded of them, but can you imagine someone in this position who feels as though no one is there to help? They can't really tell their story. No one really wants to listen. I mean, that's a tough way to go about life every day. Next slide. Healthcare provider stigma. And some of the ways to address it is a huge topic. It's something that we deal with a lot of times on our RCOR phone calls. RCOR is Rural Community Opioid Response Program. There's a lot of stigma, a lot of provider stigma that needs to be addressed, and sometimes that can be very difficult when you're looking to address something with the very people who are in place to provide services. Next slide. It is very, very, very real. And I have talked to several people who really needed medical attention, but they chose not to go to the ER because they go to the ER and they're like, you know what? If I go, they think that I'm med seeking. And, my ankle, I twisted my ankle and I thought it was just twisted, but I wrapped it up. But in fact, it was broken, but they were afraid to go because of how they were going to be labeled. And I've worked in hospitals, I've worked in state hospitals, I've worked in private hospitals. I've worked around people who laughed and joked about some of my patients that came in. There were people that I worked with who, when someone was in a mental health crisis, I've worked with people who they looked forward to getting into a dust up with a patient. Not understanding that patient was in crisis, but you know what though, was there a little bit of adrenaline for that day. So they weren't looking to help. They were actually becoming a part of the problem. And sometimes they have gone so often, they have come in so often. I had patients come in so many times. And it's like when you go into recovery, when people go into recovery for substance misuse, you talk to someone who has done it and they'll tell you relapse is a part of recovery. But just because they come back and they've relapsed, they're not to be called regulars. They're to be called a patient again. But a lot of times they're people who build up this shell in this environment because, let's be honest, when you're working with mental health, working in the field of mental health, when you're working with substance users, you're witnessing some of the worst that life has to offer. And you're seeing it manifest in people. And it's difficult to see people in this position and want better for them, but them not understanding that they should want better for themselves, and then for them not even understand how to do it. It can be difficult. So I understand why people build up this shell and they become a little callous, but it doesn't necessarily make it right. Next slide. So I thought about this question, and, for all of us who work with people, if you were to walk into one of your coworkers' office and they roll their eyes every time you came in, there was no way that you would feel welcome. There was no way that you feel like you felt you could share what you were going through, even if it was a legitimate work problem. But if you see someone's body language towards you act out, if you see them act out in this way, that's really difficult for you to say anything. Because I know I wouldn't say anything. I'd figure it out, and I'd probably mess up if I really needed their help. But when you see someone is not really welcoming of you, you leave them alone. Next slide. So this is some of the ways that I have seen where organizations and healthcare facilities have what they've done to address some of the stigma in those environments. And it is viewing people as human beings. Like I said earlier, my mom reminded me that's somebody's baby. I don't care who it is. I don't care how old they are, how dirty they are. It doesn't matter. That's somebody's child. And then the next thing is education, just to educate ourselves on what is stigma. Okay, figure out what stigma is. Okay, it's judgment. Now, why do I have these biases in place? The next one is just to understand is these are diseases. And we may not always look at it this way, but we are in the disease elimination and eradication business. We are. And it may not be that we're passing out vaccines. It may not be that type of thing. But what we're to do is we're here to do all those things in between the chemical parts, the biology parts, the biological parts, excuse me. That's what we're here to do. We're here to focus on that person. And then the next thing is to healthcare, excuse me, healthcare provider stigma, do a self-assessment. See if this is, talk to your coworkers. Is this what you really want to do? Should you do it? And it's not to tell you we want anybody to leave, because we don't want anybody to leave the field. Attrition is horrible right now in public health, and we all know that. And I'm sure some of you are feeling you're feeling that pinch with low staff. But it's reassessing and realizing that we're actually here. We're actually servants to the people who need our help. Next slide. What is the connection between mental illness and substance use? Well, years ago, I used to be a psychological assessor. And while doing the assessments, what I would do is I ask a series of questions, 4 or 5 pages, maybe 6 pages, I believe it was. And just because someone presented as one thing did not mean that's what it was. Like I said, like you see here, methamphetamine use bears a resemblance to severe anxiety. If you see someone come in under the influence of meth, they are fidgety. They're unsettled, and it looks like anxiety. But if you don't ask these additional questions to find out, then, you misdiagnose them. Someone with bipolar disorder, experiencing psychomotor agitation can be misdiagnosed as meth use because they're moving and they're twitching and their legs are jerking here and there, and they got to walk and this type of thing. And you would think that they are under the influence. I've had a conversation with someone who I think they may be under. I think they may be on meth, and I'm asking questions not because I'm trying to be Mr. Psychologist, but maybe me taking the time to have that conversation will back them down from stigmatizing somebody or labeling somebody with something that is not the case. And then opioid users also, who I've had come in, if depending on the opioid that you take, and some of them have such a flat affect that they come across as being depressed. So when you come in and they're not really responsive, and they're kind of slumped a little bit, and really indifferent. Shoot, yeah, on the surface, depression all day. But when you start asking questions and finding out what is actually going on, then we can get to the root of the problem. And then again, the last one, psychostimulant use can mirror a manic episode. If you saw anybody on cocaine, they are just busy. They can't settle on one thing. They're here and there and they're everywhere. But unless you have these conversations, and this is what the emphasis of this training is to take a deeper dive, have a conversation with someone, not to stigmatize. Don't let that stigma cause you to label someone with something that is not the case. Next slide. This came, these are some of the steps that, and I pulled these right off because what I didn't want to do is I didn't want to create I didn't want to create something new. I mean, what's here is it's functional, it works, but we have to work it. And it's talking openly about SUD and mental health. It's educating yourself and others, like I alluded to earlier. Educate yourself. Find out what is the real issue. Some of us do this so much every day that we don't even realize what we're doing anymore. And it's not that we're doing it poorly. I mean, yeah, we're performing well. But sometimes you have to peel back the layers to just get to the root of, okay, what am I doing? I'm helping people. This is what we're doing. And to be conscious of language. Like I said earlier, we don't use abuse anymore. People do. And these are opportunities for you to share with people when they say, oh, you're a drug addict. No, well, maybe about a substance misuser. It's just that stigmatizing language that we've got to address when we can. And these are not long drawn out conversations. These are, drive-by conversations. You hear someone say something that is not correct. Just, hey, look, you know what? I know that was the term, but maybe try this one. And then encouraging the equity between physical, mental illness, and SUD. Just like with someone who is diabetic, and we've had these conversations on some of my calls, when people are incarcerated, or even when they're detained and they're diabetic, they get their medications. If someone is if they are being detained, a lot of times they don't get their SUD medications. Sometimes they don't get their mental health medications. Now, it may take them a while before they see the doctor and they'll get mental health medications, but there's a push to look, we need MOUD in the jails. Some are for it, some are not. But we've got to look at these as the same way. Just like I said, if someone came in with a physical ailment in the jail, they would attend to that. We need to look at it the same way with these others. Again, showing compassion for human beings, showing compassion for the challenges that they're facing. It's really difficult I know, like if I'm frustrated, it's easy to just snap out of being frustrated. Couldn't possibly imagine how it would feel to be in a manic episode and someone just saying, "Oh, snap out of it." I'm simply frustrated. My frustrations will go away. I have no idea what are the triggers that cause this person to have a manic episode or what have you. I don't know what causes this person to use substances. I don't know. So it's being mindful and to be compassionate that, you know what, this is, and I've said this several times to several of my grantees, and I say that people are not just sitting around watching Netflix and say, you know what, I think I'm going to smoke meth today. There's a trauma behind that. And we got to be compassionate enough to understand that there was something that caused this. They didn't just up one day and decide to do this. There was something behind it. Something precipitated these acts. And the next one is, in choosing empowerment over shame. This goes back to language. Being able to talk to people in a drive-by conversation, just a quick word. No, man, I don't think that's right. Look at how we've changed a lot of things. We don't say homeless anymore. Many of us do. We slip because we've said it for decades. What do we say now? Unhoused. That's a little different than homeless. It puts the emphasis where it needs to be. Just be honest about treatment. Like I said earlier, when I talk to peer recovery specialists, or when I support specialists, or when I speak to people who are managing their mental illness, people want that person. When you are truly compassionate, they see that person in crisis. They want them on the other side. And the honest part about this is you have to have that conversation with them to say, look, man, it may be a bumpy road. I can help you through it, but it might be bumpy. It may not look how you think it's going to look at first, but being honest about treatment is one of the first steps. When you let them know that if it's substance use, look, you're going to be in recovery. Hey, you know what? 5 days in, you might want to leave. And you know what? It's okay. I understand, but you are welcome back. Being honest about the treatment is another thing that I think will destigmatize this a lot. And it's that personal stigma for those who are challenged with this. Media. The next is I mean, again, I alluded to that earlier. When we look at the images that are shoved in our faces, on our phones, on a television, I mean, media can be stigmatizing. Now, what has happened is people are now a lot more conscious about the content that they're pushing out because people are calling them on it, and we've got to do our due diligence with that. And then again, don't harbor self-stigma. And that's for all of us at any point in time, whatever it is that we're doing. Stigma is really guilt. It's carrying guilt with you. And we can dump it as quickly as we can. Sometimes we don't know that it's guilt. But when it's someone who has a mental illness or someone who is a substance user, that's something that we need to talk to them about. We need to encourage them in that area. Oh, I know that you didn't do this on your own. You didn't just jump into this space and this is the life that you want. That's not the truth. And I know it's not. You're better than this and we can help you. And, all this encouraging conversation to help them to not harbor that self-stigma or guilt. Next statement, next slide. So we want to have your questions and we want to have a discussion. One of our plans for this was to schedule for an hour, but let the presentation be 30 minutes because we want the discussion. We want to know what you think. We want to hear from you because you're on the front lines. This is what you do every day in some form or fashion. You've seen a lot of this. You've experienced it. We want to hear from you. So you can unmute yourself if you like right now and, share any questions or discuss anything you would like. Or you can put it in the chat.
Hi, I'm with Together Veterans and Witchy, and I've noticed that there's a lot of cross between, with talking about suicide also and stigma with that, and with, I think, I don't know, how do you approach kind of interdisciplinary? I know we talk about the mental, it's just I know that sometimes we're starting to see communities start shifting their focus also to, SUD, and so just kind of I don't know, what's your approach to kind of being more interdisciplinary where when we talk about suicide, we're also talking about this and we're also talking about this and all these other factors?
Well, I think one of the first things that we can do is just have programs in schools, because I think if the program doesn't have to directly address suicide, but I think if a program is in place, then it gives kids, students an outlet to even have that next conversation, but if nothing is there, it makes it more difficult. Even if it's a life skills training or something like that, somebody that they can develop a rapport with to have a conversation with.
Thank you. That's an awesome answer. Thank you.
And we do have another question in the chat from Taylor. What are some ways to work with lawmakers in policy creation to ensure more inclusive and non-stigmatizing language?
That is a big one. That's a big one. I think that is the push right now. Here's a part of the issue. Because we're looking for something nationally, right? But if you think about it, each state is its own country, so to speak. You have one state that's decriminalized substances, and then you have another one that hasn't. I think it starts at the state level. That's a really good question, and I don't have an immediate answer for it because I know that there are a lot of people out there working on it, and a lot of it has to do with having someone who understands this, having a seat at the table and having that conversation. But yeah, I couldn't even give you a great answer for that one just yet, because that's something that a lot of people are pushing for, to be able to get in front of the lawmakers and have the conversation about, look, can we change some of this?
Thank you so much for the question, Taylor. And please feel free to keep throwing any questions in the chat. You can definitely unmute yourself. If you have any other questions or just thoughts on Ivory's presentation today, if there were any topics that came up that you found to be interesting or any follow-up, we would love to hear from you. So please keep it coming either in the chat or unmute yourself.
I'm Frances Gates, and I joined late, and I appreciate so much, Mr. Tubbs. I apologize that I've joined late due to the time change here, Mountain Time. And thank you. I think I work for a Native American tribe, and one of the things that I think that is important for tribes to start discussing is that we have cultural concerns about even people asking questions of us.
Right.
And through that, we can even block doors with fellow employees when they're trying to work with others on behalf of clients. Now, I don't know if others have experienced that, but if that is the culture within our tribe among employees, we're human beings, and we're not going to just carry that between employees. We're going to carry that out to clients.
Absolutely.
So I think that part of the reality of being Native American is respecting culture. However, beginning to open the door to broad discussion so that employees and people who work for tribal health, public health, who work across the board, and maybe chair council, anyone can put this on the table and say, you know, we're dealing with this in our family or in our community. Let's ask questions and talk together in a destigmatizing manner. And I think the very language of being cultural sometimes blocks and locks people out if they're different colors, different background, come from the city, don't. And this is the same thing with drug addiction. Oh, you're not from here. Well, we can't help you. I mean, instead of using that language, I was taught when I moved from Portland is that there is a no wrong door approach, and that may prevent someone from dying on the street or committing suicide. No wrong door means you can come into any door you want as long as it's an approachable door and ask a question, ask for help. And then if I don't have the answer, I will find someone who can. And so we have to start by destigmatizing how we treat each other in our jobs and in the workplace and on tribal members, and be fluid, become more fluid. Does that resonate with anybody here who's Native? Or is it just me?
Well, I got Cherokee in me, so yes, it does resonate.
Thank you.
And that's what it boils down to.
I would agree with that. Excuse me,
Conversation.
Marla Bullbear. I really think that's an important point that's been made. Thank you very much for that.
That's what this training was about. We wanted to have, and we had a discussion with a few of us on the team. You know, we wanted plain conversation. You know, we don't need any psychological terms. We don't need all this technical jargon. We need to have a plain conversation. You know, like they say back home, keep it 100. Let's come, let's keep it straight. Let's talk, because what happens is when you speak that way with others, that's when the truth comes out. That's when the biases come out. When you don't have I have no agenda. I have absolutely no agenda. If we're talking and we're having real talk, as they say, that real talk is what is going to motivate the change. And, you know, like you said, Francis, you know, culturally, you know, so many of us, I think at this time, you know, SUD looks like everybody. Mental health looks like all of us. I could not possibly care less who assists someone in that place, but some people do. And we have to be mindful of that.
I think part of it is the funding. That's what it boils down to with reservations. And when you are a tribal member, when it comes up to paying for your services, everybody goes like this. They're pointing at somebody else to pay for it. And so I could give you a list of people that need services right now, today, and they can't get it. And we've exhausted both lines, and, guys are stealing from the local store, and the cop says, oh, that's okay, because they don't want to lock them up because they don't have to pay for their jail time. And then they don't want to get them services. And, I'm sorry, but the system is failing miserably from where I'm standing. It's horrible. I have people that have been had to go through so much for an entire year. I worked with this family to get someone assistance, that had both substance abuse and mental health issues and substance use. And so luckily with one, we were able to get them into services. They get an injection once a month. They're doing well. And I helped desperately with another one, and they're still, you know, everybody's saying short of killing somebody, this guy is okay, you know. And so now we're worried about his 5-year-old son that he has care for. The family is burnt out and fried because there's no one that will come and you know, and save the day for them. There's no heroes out here anymore. And, you know, I could go on, but it's a height of frustration for me right now, because I really feel that it really doesn't matter which direction you point, we're all failing miserably. Hate to be the downer, but I think that's the reality. You know, nobody wants to pay for it. Everybody wants to keep their money. And no one has enough money to pay for all the services that are needed. So, you know, that's part of the problem. That's, I think, helps to fuel the stigma. I think it helps to fuel the stigma.
Of course it does, especially when you don't have services in your area, and then transportation is non-existent to even get them the services. So yeah, I don't think you're being a downer. I mean, you're telling it like it is, and that's exactly what we're looking for. You know, it's the truth. The truth of the matter is that, you know, there's not enough money for the services that are needed in the areas. So what do?
We had some oh, I'm so sorry to interrupt, Marla. We actually had some comments in the chat responding to your commentary. So from Francis, Marla, I agree. It can also be that culturally a person that needs help is afraid to ask for help due to not being from our area, or we do not understand their culture. So thank you, Francis, for that comment. And Francis also offered another comment just to give a little bit of information. She says, my tribe is now offering Narcan training and are working towards destigmatizing drug, substance use, abuse, as well as changing language to not re-traumatize people who struggle. Wonderful comments, Francis. And thank you so much, Marla, for providing your insight.
Absolutely.
We do have, I'm going to just give me one moment. We have some good questions in the chat. So the first is, how can we get public service announcements as TV streaming commercials to educate on substance use disorder and stigma?
Well, but this is open discussion. This is an open discussion. Anybody who is engaged in this and who has gotten one of these to air, please share your experience.
My name is Steph Falcon. I'm in Colorado, and I work for our state opioid response grant, and we've been able to utilize state opioid response grant funds for our anti-stigma campaigns pretty successfully. So one thing I would definitely shout out is get in contact with your SOR coordinator and project director within your state. If they have any questions, they can reach out to us in Colorado, and we are more than happy to share out some of our stuff. We also have like social media shareable campaign stuff that hopefully can be a zero cost sort of thing. But yeah, one other tip I would share is that sometimes if they have really short turnaround time for some of our like carryover funds, that sometimes a media buy can be one of those things that if you already have the materials ready, can be a really easy way to spend down some of those funds without losing it, if that's a problem at all. But just wanted to say that that's one strategy that might be helpful for other folks in getting those PSAs. And sometimes just reaching out to media outlets and sharing some of the resources or the people who are doing the work can help, again, get that free time in front of folks. So yeah, hopefully that helps.
Thank you so much, Steph. And I do want to point out that Steph did include in the chat a link to the Lift the Label campaign. So thank you for including that. I just followed the link. Very cool information it looks like there. So definitely something we'll be digging into. And I encourage folks to take a look at that. And thank you so much for unmuting yourself, Steph, and also providing some of that information for the group. Another question that we have, Ivory, is does research around substance use disorder have stigma embedded in the research methodology or language?
Is it embedded? I think yes and no. It depends on the study. Sometimes when the question is asked, there are people who identify with a certain term or certain phrase. So I think part of it is a lot of the research is based around getting the numbers, getting the information. It's not so much around the language always.
Thanks so much, Ivory. And I do want to, Miranda provided some information in the chat saying North Dakota's First Lady Catherine Burgum's platform is ending the stigma of addiction. She provided a link there and just said that they are leading our state in reducing stigmatized language around addiction. There are tons of resources, and I believe they would respond and help you with questions on policy. And so that is a comment there in the chat. So another link to check out.
Nice.
Bonnie mentioned that this is great information, that she wishes more of our healthcare providers, specifically ER physicians, would be more compassionate with their patients that come in with addictions.
That's always a big push, Bonnie. It's difficult because, so again, you know, the people they built up this shell, and having excuse me, having worked in a hospital, there are times where you've got to toughen yourself up, because otherwise what you experience on a daily basis would break you down. And you've got to think on your toes, and you got to think clearly. So, you know, is that a reason to be callous? No, not whatsoever, none whatsoever. Yet I understand it, and I do agree. There needs to be more compassion because it is definitely not widespread.
And Steph actually responded to that comment with a video that they put together from a provider perspective. So another link to check out there. And she pointed out that it helps have peer champions spreading the message.
Absolutely, absolutely. They are, you know, those are a resource. Your peer champions are resources that many people struggle to employ just because of funds, as Marla mentioned earlier. With services, they are some of your champions that will get out there, and they can get the message out there. They can get this message to the people about the services and about the help, and be able to really, I don't want to say commiserate, but really be able to empathize with them because they've been there. So yeah, I think they are huge champions.
We have some great dialogue in the chat, so please do scroll through some of that. For purposes of time, I do want to point out a couple other questions that we have. One is anyone using social media to promote anti-stigma language and beliefs that you're willing to share? So feel free to unmute yourself or throw something in the chat for the group. And please do keep your questions coming. If you have any other ones, feel free to put them in the chat, or, you know, any answers to any of the questions or anything to add, please keep those coming. We have another question here from Madison. How have you all combated misinformation, especially around fentanyl use and stigma from first responders, law enforcement, and the misinformation around fentanyl exposure?
And I
Anyone
make
like
a short response to that.
Thanks, Francis. Feel free to jump on in.
A really short response is that we're teaching Narcan. Amber Landowski, who's the other public health educator from CSKT tribes here in this workshop. When we teach Narcan, we do talk about destigmatizing use and abuse and mention that Narcan is a harm reduction tool. And then I've mentioned too that using the term fentanyl poisoning is actually what youth respond to much better to create the mistrust in who they're getting the drugs from, as opposed to using overdose, which in itself is stigmatizing, because then it puts somebody in an area where people don't want to deal with them. So basically I come out and say at an Narcan training, one of the reasons we're doing this is the tribe is entering into harm reduction, where we're really looking at changing the language, and we want to destigmatize that people who use drugs or have an addiction are not valued. We want you to know as a tribe that everyone in the tribe is valued.
Thank you so much, Francis. And Ivory, I noticed that you may have had a comment. So go ahead and jump in.
Just to piggyback on what Francis was saying, I had a grantee in Maine, and what they did was conducted a first responder training, and it was a series of trainings. And in that training, they also provided pro bono counseling for the first responders, because a lot of them were at a point of saying, you know, look, we're out here doing everything for everybody else. Nobody's doing anything for us. I think once you reach out to them and let them know that they are equally as important, I think you'll get a lot more buy-in with being able to educate them and change some of that language.
Thank you so much, Ivory. Right now, I don't see any more questions in the chat, but I do want to pause for a moment to offer an opportunity for anyone else to unmute if you had any thoughts about the last topic or any additional questions.
This is Amber. I work with Francis Gates. I'm also a public health educator for CSKT. And I just want to go back to the misinformation around fentanyl exposure, because that was a big concern of mine, that now we're teaching people to around naloxone education and how to respond in an overdose. But there was a very popular video that came out of a law enforcement with misinformation of being exposed to fentanyl. So I think just providing in every training that we have the opportunity to is saying that it's, you know, it's safe to respond in a fentanyl overdose situation. You can't overdose by touching fentanyl, right? So I think just having that education around it is super important.
It is, and I think the other piece to that, Amber, you're exactly right. I think when they see things, I don't know if everyone saw, it was probably a month and some change ago, it was an officer, I don't want to say maybe Florida somewhere, she was exposed to it, and see, those types of things are what they respond to. You know, they're looking like, no, wait a minute, this thing gets airborne and it's over, or I touch it and it's over. You're right, Amber. It's the education piece that we've got to do better with, because they are going to be the first ones on the scene. And if the first ones on the scene are afraid to touch it, I mean, it's pretty much lights out.
Thank you both so much. And Abby on this topic actually just provided a resource in the chat, a link for education and harm reduction surrounding fentanyl use. So thank you so much, Abby, for sharing that. We're getting some amazing resources here. And then Francis made another comment in response to Amber. Perhaps we need to form tighter relationships with hospitals and clinics on the reservations to discuss these concerns of stigmatizing people who need help, as well as bias towards people of color and how we interact with them as providers and responders. So great comment, Francis. Thank you so much. And it looks like we, and Francis said that her comment was meant to our broader group. It looks like we're caught up in the chat. Please feel free to keep those coming, any questions that may arise. We do want to open up As I mentioned at the beginning, we are putting together a stigma series. So this was the first, the official kickoff of that series, but we really want to hear from you about what you would like to dig into more. Ivory provided a great broad view of stigma, but if there were any topics today that you felt you would like to learn more information about, that perhaps we could provide a specific training or resource for you, we would love to hear from you in the chat. And if something wasn't covered that you would like to dig into more, and also any of these comments that came through here on the chat. So I would love to, if you want to unmute and throw some of those ideas or add them to the chat. Our team will be cataloging what we hear today to really make sure that we're tailoring our efforts towards things that you would like to learn more about. We do have another question from Taylor to the group. Does anyone have a list of alternative terminology for substance use disorder or MOUD? So if anyone has a list of that or a link, if you could throw it in the chat, or you can send it to us and we can certainly distribute it to the group. And then Marla put something in the chat just saying a simple fact sheet that gives examples of what specific wordage needs to be changed. That is an excellent idea, Marla, and definitely something we can research to see if it's already available, or certainly put something together. And then Francis would like to look further into starting successful harm reduction programs on reservations and include community partners such as hospitals and clinics. We also need money to train and hire more EMTs to respond to people in medical crises. That's a wonderful point, Francis. Thank you so much. And then Abby and Ashley both posted some links in the chat. Abby's looks like it's a language matters. And then another stigma link from Ashley. I haven't gotten a chance to open those yet, but reducing stigma towards opioid use disorder and treatment. And then Kim also provided a link in the chat, recoveryanswers.org for addiction. So thank you so much for those resources. And what we can do is we will compile these links and send a follow-up email along with the recording link and the slide deck for you. So don't be worried about losing any of these. We'll make sure that they're captured for you. And then Francis also posted a link in the chat about stigma-free terminology. Thank you so much for that. Another topic idea is tips for bringing this conversation to a younger audience, such as programming for schools on this topic. Excellent, Amber. Thank you. Like we have another message here. Gail provided a topic idea. I would like to see more education and resources for mental health and mental illness to help decrease the stigma. So expanding on Ivory's discussion of that today. Thank you so much for that, Gail. And just to take a quick, I am going to go ahead and launch a poll here. This has the larger scale topics that Ivory covered today in the presentation. So including the things that you're providing in the chat, which please do keep those coming. We would love to hear from you about things today that you would like to have more specific training. So you should see that poll pop up. And if no one is seeing it, please do pop that in the chat or unmute yourself and let me know. But it does look like we're getting some votes there. And I'll keep this open for a minute or two to allow everybody to provide their thoughts. And it looks like we have so far about 22 responses, and we are almost tied for emotional impact of stigma, the role of stigma in healthcare, and how to address stigma. And yet they are nearly tied here. So that is super helpful information for us too, to add to the list that we have. You know, as I mentioned, we'll be doing a little mini series. So please do wait to hear from us. We'll certainly provide everything through the email that you provided for registration. All right, it looks like the responses are slowing down. So I'm going to go ahead and share the results with everyone to see where we landed here. This is super helpful for us. So please do keep the ideas coming. We are going to go ahead and paste a link in the chat. Part of our program and our technical assistance center is getting input from you on what you thought of the webinar today. So we're going to go ahead. Margie posted that link in the chat. I would also love if you want to be added to our mailing list and you haven't subscribed, feel free to put your email address in the chat. And if you would rather not share that, I'm going to go ahead and put our email address in the chat so that you can email us to subscribe as well. So we would love to hear from you, and please keep the questions coming. If it's something that we don't address, we can follow up with you. We can follow up with you to make sure that we get the questions answered, and any comments that keep coming in will be sure are captured. I do see some email addresses coming in. I am going to just share our final slide that has all of our specific contact information as well. If you would be interested in reaching out to any of us at any time, we would love to hear from you, and very much would appreciate your time filling out that survey. And after, you can feel free to, this is the end of our presentation, but you can feel free to stay on if you have any questions for any of us. We will be here through noon Mountain Time. So, and of course, even a little past that, if you had any specific questions you wanted to connect with Ivory on. And we really appreciate your participation today. Please be on the lookout for more from us. We hope you enjoyed today's topic, and the discussion has been so wonderful. So thank you for your engagement and the resources that you shared with us.
Thank you, everybody.